That I might come up with, say, a 5 or a 10-point quiz question about the heart's intrinsic conducting system. 5 or 10 points about the heart's. What do you mean? How do you see it as 5 things? Well, here's the 5 bubbles right here for you. I have asked students in the past, can you list for me the 5 structures of the heart's intrinsic conduction system? The SA node, the AV node, the AV bundle of His, the bundle branches, and then the Purkinje fibers. I know it says some stupid other thing down here. But I told you last week, didn't I, that we should call these Purkinje fibers, or nobody's going to know what you're talking about unless you call them Purkinje fibers, because only our book, and only in this most recent edition, really, have they started calling them something else that they just made up. So sure, I might ask you to list for me the structures of the heart's intrinsic conduction system and then tell me one function for each. I've made that be a 5-point quiz question at times where listing the structures is a ½ a point each, and their functions a ½ a point each. It's like 5 structures and functions, 5 points, ½ a point each. Or I've made it be a 10-point quiz question. But then it could be catastrophic, couldn't it? If somebody does it. I hate to offer a catastrophic. Hopefully, if you blow something entirely, you'll still get 5 points in the quiz. Like last week where everybody got all the antibodies right. And then many people told me about something completely unrelated to blood clotting in their second question. It happens, but I'm hoping at least you'll get half of it. Remember, the SA node's job is to initiate an electrical signal. Its job is to spontaneously depolarize, to spark an electrical signal, and then that signal spreads throughout the atria, causing atrial contraction. The AV node's job, then, is to receive that signal and cause a delay, a pause of 0.1 seconds. And then the bundle of His job, sort of the same as the bundle branch's job, is to carry a concealed, hidden message through the interventricular septum to the apex, where the Purkinje fiber's job, then, is to deliver that electrical signal to the myocardium, the ventricles, beginning at the apex and then spreading superiorly so that the ventricular contraction will spread superiorly and bring those ventricles out from the bottom up like we want them to, since their exit waves are at the top. Everybody good? It's easy, right? The intrinsic conduction system is pretty easy. I always think we spend too long on it. But it's totally new, I think, often to students who've never heard anything other than maybe the pacemaker before we get to it. So it would be easy for you to tell me those structures and functions, wouldn't it? You know, it occurred to me in my haste last week, because I was expecting a catastrophic emergency. In my haste last week, I forgot to introduce this term to you that I was hoping to introduce. I don't know if I have many test questions. It may never come up for you. But there's this phrase that's out there that seems like you got to introduce it here, or you might go your whole life without ever hearing it, and that would be negligent on our part. So, what the heck is a functional syncytium? Oh, it makes perfect sense. Why? Whenever you see IUM at the end of a word, that's referring to tissue. Like epithelium had that IUM at the end. We had it other places, this IUM, like perichondrium, periosteum, we talked about that. Whenever you see that IUM, or it could be EUM also, we're talking about tissue. This is a tissue that functions synchronously. The atria act as a functional syncytium. They all act at the same time. All the atrial muscle cells, I want you to think, contract essentially at the same time. They function as one, the atria do. Because this single electrical signal spreads through them, and then both atria contract. Remember how the electrical signal spreads is through intercalated discs and the branching cardiac muscle cells that can help to disperse that signal through many intercalated discs to all the atrial muscle cells, and then all the atrial muscle tissue acts as one, or acts as a functional syncytium. Now, a fraction of a second later, we're going to need the ventricles to act as one. The ventricles are a separate functional syncytium, a separate tissue acting in sync, where we need all the ventricular musculature to contract as a result of just a single electrical signal, basically. So the atria are one functional syncytium, and the ventricles act as a separate functional syncytium. You already just spent one. But I love when we have a phrase where all the parts break down and make sense. It's just a tissue that's functioning in sync. The atria and the ventricles, you know, they never show us this. I'm going to draw it. Gotta make it really, really good. They never show this. But there is a fibrous structure running through the walls of the heart that stop an electrical signal from spreading directly from these atrial myocardial cells directly into those ventricular myocardial cells. Has anybody thought to themselves, wait a minute, these black arrows are sending a signal through the atrial muscle? What prevents that signal from spreading right down into the ventricular walls? There's a non-conductive fibrous connective tissue framework in there that prevents the atria and the ventricles from acting together. We don't want them to act together because we need the atria to complete their contraction before the ventricles start theirs. So they are separate functional syncytia. They're not linked up. Atrial muscle cells are not linked up by intercalated discs to any ventricular muscle cells. Does that make sense? Oh, you're right.
If the pacemaker's only in the right atrium, how does that signal get over to the left side?
Because all of these muscle cells are connected over to these muscle cells, one cell at a time by intercalated discs.
Okay, so they don't use a bundle of this on the top?
No, not for the atria, not at all.
Okay.
Not at all. It just, they try to use a phrase here, the internodal, maybe not internodal pathway, what do they call it? Yeah, they used to put a word in. Now they don't. That's okay. You don't need a word. It just, I want you to think that the black arrows are carrying that electrical signal straight across from one atrial muscle cell to another. So you only need it to be in one side. And then it gets, the electricity gets everywhere. Okay.
What is that called?
What is what called? Internal and fibrous skeleton? No, I don't know the name. I just wanted you to see that there's a non-conductive structural component where the pink here is not linked up electrically to the pink here. And then you can't really see that on the picture. I mean, it looks like the pink is continuous. Would have been helpful if they had shown it to us without that. See, this picture would lead you to think that electricity stimulating these cells could just spread right into these cells. See how the pink is continuous? But they are not connected electrically to one another. There has to be a sort of an insulating non-conductive material in between. There's a connective tissue, but it's not something that you could, let's say, easily dissect out of the heart or show. So they never even show it. But like functionally, you have to know that it's there. Okay, then how about this? It's probably good then that I think this is the last picture of review from last week, like as potential quiz question, because this is going to launch us into our new stuff here. This is what I really need to remind you of. I think maybe with my last safe breaths of the evening last week, I was trying to tell you that the autonomic nervous system's branches, sympathetic and parasympathetic, both innervate the heart. Does this sound familiar? Right? The sympathetic is that fight or flight emergency response branch of the nervous system. Maybe we could just write it out like this because I don't think we did last time. The sympathetic, there's my C, nervous system, has two influences on heart activity. It can increase the heart rate and it can increase the contraction strength, I'm abbreviating, contraction strength of the ventricular myocardium, making the ventricles contract hard. So they'll actually inject more blood when they contract them. We said this, but we didn't write it out last week. I was starting to get nervous. And then the parasympathetic branch of the autonomic nervous system, that's the resting and digesting housekeeping branch. It influences heart activity only one way, by decreasing the heart rate. So after an emergence, the sympathetic wins out control over your heart and other organs during emergencies or stress. But then after a stress passes, after you get off the elliptical machine, a self-induced stress exercises, after stress or anxiety passes, after you hand in your NQ2 exam or whatever, and the anxiety starts to dissipate a little bit, then the parasympathetic takes back over, right? This is in control of your organs all the rest of the time that you're not feeling freaked out or nervous. This is the resting and digesting branch, right? It takes back over, and it restores resting heart conditions by bringing your heart rate back down. But I wanted you to see a little bit of asymmetry here. That the parasympathetic can decrease your heart rate at the sympathetic increase, but it can't also decrease your contraction strength. See how the purple neurons are shown to only be innervating the intrinsic conduction system, and the purple neurons are not shown to be innervating the ventricular wall down here? Sort of like they're not analogous to the green ones that are shown. The contraction strength of the sympathetic nervous system increases, just comes back to normal on its own over time, once that sympathetic starts sending signals. This is a good jumping off point for us to move forward. So I guess I could have asked George questions. I didn't ask any about this. It was all blurry there most likely. Everybody over here? Everybody good? Look, the autonomic innervation of the heart. Okay. Then I would ask you to meet me at figure 18.16 it's called these days. Check out figure 18.16, normal EKG.
Probably come Monday and do the same thing. Just stay here all day. So whenever you
This is kind of
want to be
tricky.
here.
We have a machine called an electrocardiograph machine, and it gives you a printout called an electrocardiogram. And if you use English to write that whole word out, then the appropriate abbreviation would be ECG in English, right? But the machine has historically been called an EKG machine, and its printout called an EKG. So whether you use the EKG abbreviation or ECG, it's the same thing. It's just whether you're saying electrocardiogram in, like, maybe it's German, I'm not sure, where you use a K. So ECG or EKG, same thing. In our class, we have to really deliberately attempt to limit ourselves and just talk about the very normal EKG. An EKG, of course, is a diagnostic tool for diagnosing all sorts of electrical problems with the heart. And you could take pathophysiology class if you want to, and we'll talk about 20 different things about that you can diagnose with an abnormal EKG, but we're just going to stick to what's normal here. And it's really, really, really simple. You know, you place electrodes at various places on the body. They're going to monitor or detect the electrical activity of the heart. And we see these three deflection waves on a normal EKG. A little blip in the beginning called the P wave. A little blip at the end called the T wave. And in between there's this massive disturbance, the famous big tall spike of an EKG called the QRS complex. So the letters are all in order if you want to say that there's a P and then a QRS complex and then a T. But it's really just three simple things. A P in the beginning, a T at the end, and in the middle, a big spike called the QRS complex. You've seen this QRS complex depicted on, like, I don't know, album covers, or on TV shows. You always see somebody laying in a hospital bed and there's a monitor next to the bed and we see that blip going. And so you probably know that big spike already just from living life. But I want you to see what electrical events of the heart are causing each of these three deflection waves. The P wave is created when the machine detects the electrical event of the atria depolarizing. When the SA node depolarizes and then we get a spread of electricity through the atria, which is going to cause them to contract, that spread of electricity through the atria that depolarizes those atrial muscle cells, that's causing the P wave to happen. So you get atrial depolarization associated with that P wave, causing the P wave. And then we get the massive electrical disturbance called the QRS complex when the ventricles depolarize. So once that concealed signal goes down the bundle of His and its bundle branches to the apex, and not yet, but then when it hits those Purkinje fibers and the apex of the heart lights up and we start to have electricity spread superiorly through the ventricular walls, causing ventricular muscle depolarization and contraction, then we get this. When the ventricles depolarize, essentially when they contract. They become electrically stimulated and they contract. When they become electrically stimulated, we get this. Ventricular depolarization creating the QRS complex. And isn't that really the big event of the heart, is the ventricles contracting? It really is. Finally then, when the ventricles electrically reset themselves, ventricular repolarization, that's a significant enough electrical event that it's also detectable at the chest wall with electrodes, so it creates that T wave at the end. We said it fast, and we stopped before we discussed any pathologies. But I'm fearful that when you go home, you try to memorize the 3 deflection waves and what electrical events cause them under the threat of a quiz question, or no, next week we'll have an exam. So under the threat of there being an exam question on this, here's what's going to happen when you go home. You're going to recognize an asymmetry. You're going to be like, wait a second, something's missing. You're going to say this to yourself when you get home. I see the ventricles depolarize, and then I see them repolarize. I see the atria depolarize, but I never see the atria repolarize. Because a repolarization is always, always, always way, way, way smaller of an electrical event than a depolarization. It's look, the ventricles depolarize, big event, and then a way smaller electrical disturbance is when they repolarize. Got it? When the atria depolarize, this is all it creates. So then when they repolarize, it's a tiny, tiny little thing. It's not appreciable on a normal EKG. And the repolarization of the atria happens to take place when the ventricles are depolarizing, so it just gets entirely swallowed up in here. It gets swamped out, like flooded out by the ventricular depolarization. You can't see atrial repolarization. It's too small of an electrical event, and it gets washed out by the ventricular depolarization. So it's not that you missed something, or that I forgot to tell you about where the atria repolarize, which is what you might think when you go home and try to see this. It's the relative size of these 3 deflection waves. If those relative sizes start changing, that could indicate problems with the heart's intrinsic conduction system or electrical systems in the heart. And it's also the timing of these things. Like from the start of the P to the start of the QRS, which by the way is called the PQ interval. I'm going to have to send an email. We don't need to know the PQ interval, but from the start of the P to the start of the Q, the timing of that can change when there's certain pathologies. From the end of the QRS, from the S to the start of the T, that's sometimes called the ST segment. That can become longer or shorter when there's certain pathologies, electrical problems with the heart. From the start of the Q all the way to the end of the T, the QT interval, those are all, the timing and the heights change to indicate different pathologies. Okay, let's stop. Normal EKG. Now I'm going to ask you to meet me, if you would, on figure. See, I guess they're now calling this a focus figure, and I can't show you the piece of it that I really, really want to show you, at least not large, I think. So, can you find this picture in your chapter? I don't want you to see all those graphs, so don't already start getting nervous about the graphs. I just want you to see the pictures of the heart at the bottom. And it's like focus figure 18.2. Thank you. 695. Check out page 695 if you've got the 11th edition. And they didn't give me a figure number up there. Look at that, unfigured. It was a rush job when I sent this out. Somebody's on drugs over there. Anyway, I really, in previous editions of the book, I was able to show you just this picture at the bottom and make it take up the whole screen, because I really just want you to focus here. And I know once there's a graph up there, students are already receiving like traumatic information. Don't worry, we're not using those graphs at all today. Look at these pictures down here. This is where I want to introduce you to the fact that a single heartbeat or cardiac cycle one cardiac cycle, or heartbeat, can be broken down into 2 major phases, systole and diastole. Systole and diastole. It's quite possible you're already familiar with these words, or at least the adjective forms of these words, systolic and diastolic, because if you've ever been trained to take a blood pressure, and I often in A&P2 particularly, have lots of students who are already clinicians of various levels and have already been trained in their life to take a blood pressure. You know, when we say that a blood pressure is like 120/80, that top number is the systolic blood pressure, the bottom number is the diastolic blood pressure. So that's where you may have come across these words before, if they're familiar to you. If not, no problem, we're going to define them right here. Look, in one heartbeat, you know this. Just think about the ventricles with me. This is all a story about the ventricular events. You ready? Here's how the heart works. Ventricles contract, they relax. They contract, they relax. They contract, they relax. One contraction and relaxation of the ventricles, it's one heartbeat, a cardiac cycle. When the ventricles are contracting, we call that period of time systole. When the ventricles are relaxing, we call that period of time diastole. That's all there is to it. Systole refers to the period of the heartbeat when the ventricles are contracting. Diastole refers to the period of time during the heartbeat when the ventricles are relaxing. Literally, you could think of the words as contraction and relaxation. But just know we're talking about the ventricles. Systole really is like ventricular systole, but the ventricular adjective is unnecessary. It goes without saying that we're talking about ventricular events. So you could just call it systole and not have to go through all the writing of ventricular systole. What we're talking about, ventricular contraction, ventricular relaxation. There are two phases to one cardiac cycle. Contract, relax, that's all. But now, on that focus figure 18.2 that we're about to go to, I want you to see that our book wants us to break systole down into two subphases. So if you can think about that contraction happening in super slow motion, we're going to talk about two different phases within systole while one contraction is happening. And then the same thing with diastole. When the ventricles are relaxing, we're going to break that into three subphases. A single relaxation broken down into three subphases. Let's just write out the names of these subphases and then I'll use the picture to show you. Systole includes a subphase that our book wants us to call, and I would want you to call, isovolumetric contraction. And again, I'm abbreviating contraction for the names. Isovolumetric, everybody, means same volume. There's that iso prefix again. Where did we have iso before? Oh, when I drew you a beaker with compartment A and compartment B, and I said, oh, one's hypertonic to the other one, which is hypotonic. But then after we let diffusion take place for a while, then they're going to become at a state of equilibrium, and then we said they're isotonic to one another. Iso always means the same. They're going to become the same. Those two concentrations are on either side of that semi-permeable membrane. Look, this is a same volume contraction. Nothing's coming in or out of the ventricle as well. So there's a period of isovolumetric contraction. The ventricle starts contracting, but nothing's leaving yet. And then eventually we get ejection. Eventually, blood leaves the ventricle and get ventricles and gets shot out into those two great arteries. So we're going to see systole as having two subparts to it. They always call them subphases. With diastole, we're going to see three subphases. We're going to see isovolumetric relaxation. The ventricle starts relaxing, and when it starts relaxing, which you would tend to think is like the filling time, but when it starts relaxing, at first, nothing's coming in yet, until eventually we start to fill it up. And then we're going to see that first blood starts leaking in there passively from the atria. So we have a period of passive ventricular filling. Try to take a period there from the abbreviation. Passive ventricular filling. And then later, eventually, just before the ventricles are going to contract again up here, the last thing we got to do before the ventricles contract is we have the atria force fill those ventricles, pushing more blood in there. And I always refer to this as active ventricular filling, even though I can't get the book to call it that. So I want you to see these three subphases of diastole. And I guess it's best if we just write them out like this, and then I'll try to show it to you on the picture. I guess you sort of explained a little bit already as well. Everybody okay if I take that down? That anybody still writing or waiting to try to take a picture? We can always pull it back up. It's not going further. Boy, I wish this picture was bigger. Check out with me bubble number 2 on focus figure 18.2 in the 11th edition. Check out bubble number 2. I don't know why they put bubble number 2 in the middle of the story, but this is where you have to start the story, I'm thinking. Watch. This is the beginning of systole, the contraction of the ventricles. The ventricles start contracting, as you know, from the bottom up. They start contracting at the apex, and then the contraction spreads superiorly, as we've said repeatedly. And we said last week that when the ventricles start contracting, first blood starts rising up in the ventricles, and then that rising pressurized blood snaps shut the AV valves. So look, they're contracting, but nothing has yet gotten ejected out of the ventricles. So the very start of their systole or contraction, we call isovolumetric. The pressure is rising, the blood starts rising, the AV valve closed, we haven't injected anything yet. Finally, the contraction continues to a point where the pressure rises so much, there's no place else for the blood to go, it blasts open these semilunar valves, as you know, and finally blood gets ejected. So then bubble number 3 says, the ventricular ejection phase. This is the second subphase of systole. They should have bracketed bubble number 2 and 3. Would have been nice if they did this. I think maybe they did in the old edition, and didn't in the new edition, so now I got another email. I wish that you would see bubbles 2 and 3 together as systole. These are the 2 subphases of systole I want you to know. Isovolumetric contraction and then ejection of blood out of the ventricles. Then we get to bubble number 4, and we're starting the relaxation phase of the ventricle. They're starting to relax diastole, right? So 4 is the first subphase of diastole. When the ventricles first start relaxing, their pressure drops way down, and the blood that we just jammed up into those 2 great arteries attempts to come back, and we know that that blood is going to close our semilunar valves when it tries to come back. So when the ventricles begin their relaxation, nothing's coming in or out. Isovolumetric. They're staying the same volume of blood in there at the beginning of their relaxation of diastole. That's the first subphase of diastole. And then we've got to wrap all the way around. Remember, this is called the cardiac cycle, right? So it just keeps going all the way around. And this bubble number 1 over here could just be right here, and we could just keep repeating the same sequence of 5 pictures. So just wrap around with me, and then see that the leftmost panel is trying to show you this. So much blood has now filled up those atria that blood just pushes those AV valves open. Remember this? What opens up the AV valves? Oh, maybe you're planning on telling me on your quiz. What opens the AV valves? Accumulated atrial blood does, that's all. And then that blood pushes the AV valves open, that blood starts leaking down into the ventricles, and I call that passive because there's no contraction of anything happening here. The blood's just leaking, so that's passive ventricular filling. Finally, just before we're going to start contracting those ventricles again, we have to have this happen. See the black arrows in the second panel from the left? The black arrows are showing us that the atria are squeezing here. This is when the atria are finally contracting to force fill the ventricles. But I don't want to call it atrial contraction, even though that is happening. I don't want to call it atrial contraction like they've done in our book. I want you to call it active ventricular filling. What actively fills the ventricles? The atrial contraction does. But I think you got to call it active ventricular filling. Because what we've done all along, through the entire story, from the time we defined systole and diastole, what we've done all along is told the story about what's happening in the ventricles. It's a ventricular story. Why in the world did they just tell us what's happening in the atria here? See, I sent them an email about it. This is one of the things that makes me worry that they're on drugs over there. We're talking about what's happening in the ventricles. The volume is staying the same, but they're contracting. What's happening in the ventricles? They're ejecting blood. What's happening in the ventricles? Their volume's staying the same, but they're relaxing. What happens in the ventricles? They're passively filling with blood. What happens in the ventricles? They're telling us about what happens in the atria. See, somebody just lost. They should be telling us that the ventricles are getting actively filled by atrial contraction here. That's why when I wrote it out, I wanted you to see this phase as active ventricular filling, meaning the atria are forcing the blood into the ventricles. And then we've been consistent about telling you a ventricular story all the way through. By the way, you can use the words systole and diastole to refer to the contraction and relaxation, respectively, of the atria. Like when the atria contract, you could call that atrial systole if you want to. When the atria are relaxing, you could call that atrial diastole. But then you've got to put atrial in front. Then you have to qualify it by saying atrial. If you don't put any qualifier in front of systole and diastole, you're talking about ventricular events automatically. So automatically that you don't even have to call it ventricular systole or diastole. But some people will, if they're telling us about something going on in the atria, they'll say, you know, atrial systole, or the atrial diastole, atrial diastole. Okay, please disregard the the graphs on that picture, because I don't see how they help us check any of the boxes we're required to check. But the phases and subphases of the cardiac cycle are on a list of things that we have to cover. Caution here, our book does a really good job of simplifying this story. I've had students come to me and say, have you seen this University of Indiana website that says that systole actually consists of 7 subphases and diastole actually consists of 11 subphases? I say, don't do that. Don't do that yourself. When our book goes simple with something, be thankful. Be thankful about it, and then don't seek out more. Yes, there's a lot of different ways. So depending on what expert you're consulting, systole could be broken down into multiple different phases depending on how you want to see it, and so could diastole. But our book, this is about as simple as you can go if you're talking about subphases. And so please don't consult outside resources that will confuse the hell out of you and make you give wrong test answers. Okay, now we're really doing good. But I want to use this, I want to do my one trick to you where I start to tell you about the next story before I put the picture up. I wanted to use this picture to do it, but because that picture is like not adequately blown up, then I'm going to steal the picture from the old version of the book that I think maybe just a couple. Oh, there it is. Look at it. Here's the old version of this picture. And I'm just going to steal it momentarily to make a few points. Are you ready for this? When the ventricles contract and eject their blood up into those 2 great arteries, the ventricles never, never, never become completely empty. They never succeed at ejecting 100% of their blood ever under any circumstances. The ventricles only eject a fraction, a percentage of their blood. It's that amount of blood that is ejected, the percentage of the blood that ejected, that we sometimes call that the ejection fraction, but that's not on our list. We don't have to know that phrase, ejection fraction. But realize that the ventricles have failed to empty themselves. Everybody see the remainder? We give a name to that volume of blood that's left in the ventricles at the end of their systole. You know what we call it? The volume of blood left in the ventricles at the end of the systole. We have to know about that remainder right there, since ventricles never 100% empty out. But there's no other great place for me to show you a picture of it. That's called the end systolic volume, or ESV, the end systolic volume. Doesn't that make good sense? It's the volume of blood in the ventricles at the end of their systole, the end systolic volume. There's nothing better you could call it. Do you remember me saying that the sympathetic nervous system influences heart activity 2 ways? I keep saying heart activity. It increases your heart activity 2 ways. I keep saying heart activity because we haven't defined a key other term that we'll eventually get to here very shortly. The sympathetic nervous system can increase heart activity, right? Remember, it can increase your heart rate, or it can also increase the strength with which the ventricles contract. If the sympathetic nervous system is telling these ventricles to contract harder, what do you think happens to that volume of blood that's left over after the contraction? It becomes less. You'd have less blood left. If you contract harder, the ventricles are going to eject a greater percentage of their blood, leaving less remainder. See what I mean? So increased activity of the sympathetic nervous system will lead to increased contraction strength of the ventricles, which will lead to decreased end systolic volume. It means less blood will be left in here. You'll get a decrease in the end systolic volume. If the ventricles contract harder, less will be left in there. Isn't that sort of sensible? It's just there's a lot of vocabulary in the way here. End systolic volume. Makes sense to you. Okay. Well then, follow this. The volume of blood that gets ejected from the ventricles up into those 2 great arteries, there's really, God bless you, there's really no great place to show it to you because you can never see it all at once. But the volume of blood that gets ejected from the ventricles with a single ventricular contraction, with a single stroke of the ventricles, the volume of blood that gets ejected is called the stroke volume. It's the amount of blood ejected from the heart per beat. Here it is. Here's that blood up here. It's the amount of blood ejected from the ventricles with one ventricular contraction, one stroke. We call it the stroke volume. Stroke volume. I'm saying this. It's abbreviated SV. What's the stroke volume? It's the volume of blood ejected from the heart per beat. Let's say you're being chased by a hungry lion. This will activate your sympathetic nervous system because you'll be scared shitless. And you're running like mad. You're panting like mad. You're seeing your life flash before your eyes. You're hoping that your life insurance policy is intact. You're running, and what should your heart be doing? The sympathetic nervous system is sending commands to your heart that's going to make your heart beat harder. That means that there'll be less blood left in the ventricles, right? But if there's less blood left, then that means that the ventricles squeeze so hard that they ejected more blood. So not only does an increase in contraction strength mean that we're going to have less blood left over, it also means, it's sort of like the same thing, having less blood left over means that we're going to go from there to here. We had an increase in the stroke volume. The volume of blood that got ejected was greater. If the ventricle contracts harder, more blood comes out. If the ventricle contracts harder, you have an increase in the stroke volume, the volume of blood ejected from that stroke, which leaves you with less blood left over. You could put these two things, I guess, in either order, but they always occur together, don't they? There's going to be less left over if we ejected more. If we eject more, there's going to be less left over. There's only so much blood in the ventricle. But then if we contract harder and more of it gets ejected, increased stroke volume, then there's less left over. Decrease in systolic volume. Okay, if you're okay so far, and nobody seems to be melting, then I would say the next thing that we have to do is we have to define a new term called cardiac output, which is abbreviated CO, but be careful here because this abbreviation is used all over everyday life, right? This is the two-letter postal abbreviation for Colorado. And also in chemistry class, it's carbon monoxide, CO. And I recently learned that it is also frequently used as the abbreviation for a certificate of occupancy when the municipality that your house resides in says, okay, we did an inspection and now your house is certified to be occupied by people, right? A certificate of occupancy. Anybody? CO? The house has a clean CO? Oh, correctional officer. Thank you. Very good. So this is all over the place, right? But in this, so it's very context dependent. But cardiac output, I want you to see, can be abbreviated CO, and it means this. Cardiac output is this. The amount of blood ejected from the heart per minute. And the reason why I said that per minute with so much drama was we had previously defined that stroke volume was the amount of blood ejected from the heart with a single stroke. But you couldn't get a lot of strokes in a minute. So you got to take that stroke volume that comes out with one beat and multiply it by the number of beats that you're going to get per minute. Does that make sense? So the cardiac output can be calculated by saying that it's equal to your heart rate, the number of beats per minute, times the stroke volume, which is the milliliters ejected from the heart per beat. If we take the number of beats and say 10 milliliters get ejected each time, multiply it by that 10 milliliters that get ejected each time, then we would say, oh, this is how much blood comes out in the course of an entire minute. So that cardiac output, it's often described in milliliters of blood ejected from the heart per minute. See, what we would do is the beats on the top here cancel out from the beats on the bottom here. They cancel each other out. You're left with milliliters over minutes. And here you go, milliliters over cardiac output. The heart rate times the stroke volume. A couple of things about the cardiac output. Can you see this with me? What would happen to the amount of blood ejected from the heart per minute? If your heart rate went up, let's assume the stroke volume stays the same. If your heart rate goes up, does your cardiac output go up or down? Up. Everybody see it? There's a direct relationship. If you beat more times per minute, more blood's going to come out of the heart in that minute. Okay. Forget about heart rate for a second. What would happen to that cardiac output if your stroke volume went up? If you can eject more blood with each beat, what happens to the cardiac output across the course of a minute? It goes up. If your stroke volume increases, the amount of blood ejected with one beat, then your cardiac output's going to go up, the amount of blood ejected across the course of a minute. Does it make sense? This also correlates, stroke volume also correlates directly with cardiac output. If either one of these factors is increased, your cardiac output goes up. Dare I say that that's algebra? Because I know if I call it algebra, then you stop understanding what you just understood. Like, oh, no, not algebra. I failed that. That's algebra. That's all that is. What would happen to the cardiac output if either one of these goes down? If either one of these goes down, cardiac output goes down. It's a direct relationship, a direct correlation. Okay. Then how about this? What I told you about the sympathetic nervous system today and last time, and maybe you were thinking it might be on today's quiz, but it's not, is that the sympathetic nervous system can increase heart activity two ways, I told you. But I was only saying heart activity because I didn't have this phrase yet. Well, you didn't have it yet. The sympathetic nervous system can increase your cardiac output. That's heart activity. The sympathetic nervous system can increase cardiac output two ways. The sympathetic nervous system can increase your heart rate. We saw the innervation where it goes right to the SA and AV nodes. The sympathetic nervous system can also increase your stroke volume. How the hell is it going to increase your stroke volume? Well, it can increase the contraction strength of the sympathetic nervous system can, which leads to an increase in the stroke volume. So the sympathetic nervous system separately influences each of these factors, and then we say there's two ways that it can increase your cardiac output. Everybody good? Nothing to it. Now you're ready. This is the end of my trip. Now you're ready for me to show you this figure from your textbook. Figure 18 point, there it is, 18.20. Take your figure 18.20 in your 11th grade. See, there's no anatomy shown on the picture. And I wanted you to see a picture when I tried to tell you what's end systolic volume and what's stroke volume. That blood that got injected up into the two great arteries is the stroke volume. I wanted to see an anatomical picture to make sense of it. They don't give that to you when they try to introduce it to you. They just introduce it to you on this flow chart here. And I think that creates trouble for students. I want you to see that what we've already covered is this story right here. Watch. If your autonomic nervous system output goes up because you're experiencing exercise or fright or anxiety, you're being chased by a hungry lion, we know that this is going to activate the sympathetic nervous system, is what we've been saying all along, which we know can increase your heart rate. What effect does that have on the cardiac output? That increases your cardiac output. See, we covered it on a different picture already, so that this just makes easy sense. Because I found that this flow chart makes people come to me with withdrawal slip. So I said, okay, we gotta solve this beforehand, where everybody's like, I get that, and then put the flow chart. Look, the sympathetic nervous system also increases the contraction strength of your ventricles, which decreases the remainder left in the ventricle, because if they contract stronger, then there's less left over, which means that more blood got ejected with that beat, increased stroke volume, which would also increase your cardiac output. We just said all this before we got to the flow chart, because the flow chart makes the shade come down, and then I can't get in. Yeah. Don't be intimidated by this simple picture, especially because we don't have to cover at all this story here. We'll make our own little flow chart of that. And we don't need this, and we don't need this. We do need this leftmost pathway down the page. But we're gonna do our trick again to cover it. And we're also gonna follow their instructions, believe it or not, and go see something in chapter 19. We're in chapter 18 now. We're gonna go to 19 briefly and then come back to here in order to understand that leftmost pathway down the page that we also have to know. Okay, so how are we gonna go about doing our trick again? We're gonna do this. Check out this picture right here. He's pointing to bubble number 2 on focus figure 18.2. Although he's using the version from the 10th edition. But here, I want you to see the ventricles just before blood starts coming out of them. The ventricles are just beginning their contraction, right? I guess this is really the best picture I have for you that shows the ventricles at their fullest point. When all the blood's already been jammed into them by the atria, and they haven't yet begun to eject any blood, this is a picture of the ventricles when they're done with their relaxation. I know it's labeled the start of systole, the start of their contraction, but it's the best picture for me to show you that they are at their fullest point when they're done with their relaxation. At the end of diastole, the ventricles are at their fullest point. The end of their relaxation, right? They've had atria jam extra blood in them, or preload or pre-stress them, and there's the picture of it right there. We give a name to that volume of blood that's in there when the ventricles are at their fullest point, just before they start their systole. We give a name to that volume of blood. We call it the volume of blood in the ventricles at the end of their diastole. It's the end of their relaxation. We call this the end. This is the end diastolic volume. The end of diastole, right? That's the relaxation is diastole. At the end of diastole, or EDV we call it, at the end of diastole, here's the volume of blood that's in it. It's the ventricles at their fullest point. Doesn't this make sense? If we could somehow increase that, if we could somehow jam more blood into those ventricles, then the next time they go to contract, more blood's going to come out. If there's more blood in there, when they start their contraction, then more blood's going to come out. The fuller they are, when they start contracting, the more blood they're going to eject. So if we could just increase this end diastolic volume by somehow getting more blood in there, then you know what else we can increase? Stroke volume. An increase in the end diastolic volume, making the ventricles more full, would mean that the next time they contract, this amount would go up, the stroke volume. You okay? If we increase the stroke volume, what effect does that have on cardiac output, everybody? It increases the cardiac output. So, an increase in the end diastolic volume would increase the stroke volume and therefore increase the cardiac output. Maybe I better make us some room to write that in that order like that. An increase in end diastolic volume, so the ventricles are even more full when they're done relaxing. That would lead to an increase in the amount of blood ejected at the next beat, stroke volume. How much blood is that? More. And then, across the course of an entire minute then, of course, this would increase our cardiac output. So then the question arises, how in the world can we get more blood into that ventricle during an emergency or a stress? When we want to increase more blood flow through the body, how can we get more blood to come back? Well, I want you to think about a single relaxation of the ventricle. Look, the ventricles are relaxing and filling, relaxing and filling, relaxing and filling, relaxing and filling. During one diastole, I want you to really break that down in your mind, really, really, really super slow-mo. Imagine if you were doing this. During that one relaxation, can the veins that are bringing blood back to the heart, now skip the atria for a second, because veins are bringing blood into the atria, but then that blood's going to go right through the atria into the ventricles. So think about the return of blood through the veins to the heart during a single relaxation. Let's try to make believe that that relaxation is taking a really long time. If we could just make the veins carry more blood back to the heart during that time, then we would be able to fill our ventricles full further during that relaxation. We have to increase the return of venous blood to the heart. We call it venous return. We need an increase in the venous return of blood because that will lead us to an increase in the end diastolic volume. How the heck are we going to get the veins to bring more blood back to the heart? Here's what you do. You squeeze them. You kind of milk them, if you don't mind me saying it that way. You milk them. You have to squeeze the veins. How the heck are we going to squeeze our veins? Forcing more venous blood, the blood in our veins, venous, right? You know there's two Venuses, right? The capital V, that planet in the solar system, V-E-N-U-S. But then this is an adjective, O-U-S at the end, meaning overputting the veins. We have to return more venous blood to the heart during a single relaxation. That's going to fill up our ventricles more, allow us to eject more per beat, and then more per minute. How are we going to get the veins to bring more blood back? We've got to squeeze them. And to show how we squeeze the veins, this is where we're going to actually do what we're told by the flow chart. God bless you. And we're going to go see something in chapter 19 to talk about how can we increase the venous return of blood so that we can increase the end diastolic volume, preloading our ventricles more, so that then they'll contract and eject more blood, give us more cardiac output. We have to go to chapter 19. So, in parentheses, I guess it is, check out with me figure 19.9 in the new version. Check out figure 19.9. I love this picture. It's so simple. Here's a picture of a vein. What makes you know it's a vein? Is it the fact that it's blue? No. Because veins could be red if they were in the pulmonary circuit. They labeled it vein. That's why. But Courtney's got a good point. Here's how you know it's a vein. There are valves. Remember we were answering Kelly's question earlier, and she said, what would prevent the blood from flowing back when an atria contracts? There are veins inside of our, there are valves inside of our veins that prevent the backflow of blood. You can't tell that, except the direction of blood flow in these arrows, showing you that little vessels are merging to form larger ones. Larger ones are merging together to form even larger ones. That's what veins always do. They're always merging smaller ones together to form larger ones, and they're carrying blood back towards the heart. You need the direction of the arrows, in large part, to have you know that this is a vein. And it might help, let's say, if there was a picture of a heart on them. I always draw a little Valentine's Day on it and try to have students realize that that arrow is pointing back to the heart, right? In a vein, the blood's flowing back to the heart. So can you tell then from the color of this vein, can you tell whether this is a vein from the pulmonary or the systemic circuit? Can you tell? It has to be a systemic circuit vein, or else it would look reddish, right? They would depict it as red to try to tell us that the blood is well oxygenated. Even though the blood is always red, they're showing it as blue here to show us that the blood is poorly oxygenated. And veins only carry poorly oxygenated blood only in the systemic circuit. So this has to be a systemic circuit vein. Anyway, that's not really the point, is it? Here's the point. We got to get our veins to deliver more blood back to the heart during a single relaxation of our ventricles, so that the ventricles will become fuller. We want to increase their end diastolic volume, so then we can increase their stroke volume. Right? We want more venous return of blood, and here's how you do it. All over your body, veins are running in between skeletal muscles, and often veins even run inside of skeletal muscles, so that whenever you contract your skeletal muscles, you're squeezing the veins. And when you squeeze the vein, like on this picture right here, the blood would want to go up, plus it would want to go down in our picture. But what prevents it from going down? Valves. So then it's got only one direction it can go. If you squeeze your veins, the blood always goes back towards the heart further. And it turns out that the veins are sort of strategically located around, between, even within your skeletal muscles, so that when you contract your muscles, it forces more blood back to the heart. Our book loves to call this the skeletal muscle pump, or up here just as the muscular pump. The muscular pump increases the return of venous blood, or it increases the venous return of blood back to the heart. So if we could just imagine a single relaxation, imagine if we were really contracting our muscles a lot during that single relaxation of the ventricle, If we contracted our muscles a lot, we force even more blood back to the heart, and then that ventricle would get fuller during that relaxation. Not depicted here, never depicted for us. This exact same principle of squeezing a vein, forcing blood back to the heart, because remember that the blood can't go backwards because of valves, so when you squeeze it, it always pushes it back towards the heart. This same exact idea is happening all throughout your thoracic cavity, where every time you breathe in and your lungs expand, the expanding lungs are squishing veins up against the chest wall. So veins all throughout your thoracic cavity are between the lungs and the chest wall. When you breathe in, that squeezes the veins, forces more blood back to the heart. So if during a single relaxation of the ventricles you were breathing a lot and contracting your muscles a lot, you'd have the muscular pump and what we call the respiratory pump of your lungs also squeezing more blood back to the heart. How do you increase venous return, everybody? By increased activity of the muscular and respiratory pumps. The respiratory pump is never shown for us, the idea that the lungs are also squeezing veins in this way. They never show that to us, but they do want us to know it. So increased activity then, I gotta make this sort of vertical, sorry. Increased activity of the muscular and respiratory pumps would give us an increase in the venous return of blood. And then we said on the previous picture already, we did the rest of this flow chart. We already said increased venous return gives you more end diastolic volumes, the ventricles get fuller. And then if you fill those ventricles up fuller, then the next time they go to contract, you're going to get an increase in the stroke volume. You're going to eject more blood if they're fuller. And then if they're ejecting more blood with each beat, then across the course of a minute, you're going to get more blood come out of the heart for increased cardiac output. I know you're chuckling because you're thinking, this is kind of a lot. You are being held to a very high standard. There's no doubt about it in this class. I'm sorry, but you're completely up to it. Look, you understand all the parts of this. I think, from your face. So, I know it seems complicated. Be proud of yourself. You're completely capable of understanding this. It is complicated. Anybody else taking a picture before we get rid of that?
No, but it kind of makes sense, because if you're being active, you probably are already breathing
heavily
and
and
contracting your
contracting.
muscles.
Absolutely. Absolutely. So more blood's going to come back in the heart for sure. Good point. It makes great sense. Well, now if we could sort of close parentheses then and return to our regularly scheduled programming here in chapter 18, then that's all that this upper left box, and we had to check this mentally, I had to check this box in my mind. They tell us we have to cover the skeletal muscle and respiratory pumps. The more you're breathing and the more you're contracting your muscles, everybody, the more you're forcing blood back to your heart, filling your ventricles more, so that when they contract, more blood comes out. And then that happens across the course of a minute. So now we've covered this leftmost pathway down the page. And we've done everything we have to do in chapter 18. Oh, no, maybe another thing to do. Maybe another thing. But it's the last picture anyway that I'll show you from chapter 18. Okay. One thing I didn't tell you about the cardiac output, and I know I've written this exam question, so maybe it can come up next week, I don't know. But I want you to know that cardiac output is dictated by the oxygen demands of your tissues. So across the course of a minute, if you're really, really active, like let's say you're doing jumping jacks for a minute, then your skeletal muscles are consuming oxygen like mad, removing oxygen out of your bloodstream, right? There's a lot of oxygen demands from your tissues if you're doing jumping jacks. Cardiac output has to go up to meet the demands of the tissues. If you're sleeping, your tissues are demanding very little oxygen during that minute of sleep, let's say. So your cardiac output can go down. Cardiac output is always dictated by the demands of your tissues, and then we're going to have to raise it or lower it through these mechanisms in order to meet our tissues' oxygen demands. I don't think I said that about cardiac output. That's the one I wanted to. Then the last point, I guess, and it will be the last point of chapter 18, is that they want us to understand the parasympathetic nervous system, and they used to give us a separate little flow chart for it. Now they try to include it in this flow chart, leading to more student confusion, and it's no good because they're telling us what happens when the parasympathetic nervous system decreases its activity. That's not helping us. One of the things we have to understand, it's on our list of stuff, is what happens if we have increased activity of the parasympathetic nervous system? And we already said this, that the increased activity of the parasympathetic nervous system will cause a decrease in our heart rate. Remember us saying that? The parasympathetic it innervates the intrinsic conduction system in such a way that it could decrease your heart rate, bring it back down to normal after an emergency or a stress passes. What we now know then is that if you decrease the heart rate, what happens across the course of a minute to your cardiac output? It goes down. So the parasympathetic nervous system decreases heart rate, leading to a decrease in your cardiac output across the course of a minute. This is all we need to know for the parasympathetic nervous system. We need to know what effect would it have if there was more parasympathetic signals going to your heart. What effect would that have? Increased parasympathetic innervation of the heart. But see, the flow chart doesn't tell us that. It's telling us what would happen if the parasympathetic decreased. They blew. Okay, now we're officially done with chapter 18, but there are a few things for us to cover in chapter 19 before we take our quiz and our break and declare ourselves done with the cardiovascular system. So, there we go. We're going back to chapter 19 now. Where I'm going to ask you to meet me at figure 19.9. Just a couple more pictures before our quiz. Check out figure 19.1. Wait, 19.1. And then look at the colors on the picture and the labels and tell me, is this a picture of the systemic circuit or maybe we're reviewing for our quiz. Is this a picture of the systemic circuit or the pulmonary circuit? It has to be the systemic circuit. Here's why. Look. See the arrow is showing that blood is coming out of the heart here? So that makes these arteries, right? And if the arteries are shown as red, indicating that their blood is well oxygenated, then it has to be the systemic circuit. Otherwise, the arteries in the pulmonary circuit are blue looking. The pulmonary trunk is blue looking. The pulmonary arteries are blue looking. Everybody okay? So it has to be the systemic circuit, where veins are carrying poorly oxygenated blood back to the heart. This is a picture of the systemic circuit. When arteries leave the heart, like the aorta, let's say, it immediately starts branching to give us smaller arteries, right? And then those smaller arteries branch further to give us smaller and smaller and smaller arteries. Eventually leading us to the smallest of arteries called the arterioles. And I wonder if we've made this point before, that when you add OLE or ULE at the end of the word, maybe we made this point in AP1, but not yet this semester. When you add OLE at the end of artery, or OLE at the end of bronchi, those airways in your respiratory tract, bronchioles, then we're talking about microscopic ones. But it's not always an OLE, it can often be a ULE. Like a little tiny tube in the body that's microscopic is often called a tubule, or a little duct can be called a ductule. But so whether it's OLE or ULE, we're talking about a tiny, tiny microscopic version of whatever the word root is. Tiny artery meaning arteriole. It's the arterioles that are our smallest arteries, and then those lead us into capillary beds, where we make exchanges because the capillary walls are so thin that we can diffuse things into and out of the blood. This is where we would, let's say, drop off oxygen to our tissues, pick up CO2 from our tissues, drop off nutrients to our tissues, pick up their nitrogen-containing wastes, let's say. We're going to make exchanges at the capillary level. And then capillaries merge to form little tiny microscopic veins, the smallest of our veins. So if they're microscopic, we're either going to put an OLE or a ULE at the end of their vein. Look, little tiny veins are called venules. So if I hadn't used the terms arterioles and venules before, really I think it's the main reason why I'm introducing this picture. Capillaries merge to form little tiny veins called venules, and then those merge to form slightly larger veins, which merge to form even larger veins, which merge with others to form really larger veins, and eventually all of those will bring us back to the superior and inferior vena cavae, the largest of all veins, and then the right atrium that you arterioles and venules. The main reason why I put the picture up, just so you can see, there's little arteries called arterioles, there's little venules, little veins called venules. So you see the levels of the blood vessels as they branch or merging. And how about this? I always have this issue when I teach the lab. In like the chest of the cat, let's say, with, you have cat, are you seeing blood vessels in the cat? The wet specimen, and you're seeing like blue latex injected veins and red latex injected arteries. I'm hoping you're seeing that in there. Many times, like on a human model or in the cat, a student will point to a large vein and then say, oh, I see where that vein branches to form these two smaller veins. Veins don't branch. It's the opposite. The two smaller veins merge to form the larger vein. Veins don't branch. Veins merge. Think about it. Veins are carrying blood back towards the heart from the capillary beds. So we're always having tiny ones merge together to form larger ones. If you say that veins branch, I'm not sure you're getting the idea about which direction the blood is flowing through those veins. It's flowing from the smaller veins into the larger vein. The smaller veins are merging together to form the larger vein. Larger veins don't branch to form smaller veins. I guess it's sort of like semantics, but I think it's an understanding of the physiology of what direction is the blood flowing through these veins. See, smaller ones are merging to form larger ones, that merge to form even larger ones. And that's the direction that the blood is flowing in the veins. Whereas arteries branch, right? Big arteries are carrying the blood into smaller arteries that they branch into. And then those smaller arteries branch further, forming even smaller ones. Arteries branch. Veins merge. They don't branch. So think about that when you're trying to identify those vessels. Maybe it's already too late for this for your lab or something like that. But you know what I'm saying, where somebody might point out a big vein and then say, oh, I see where it branches to form those two smaller veins. You know, the two smaller ones merge to form the bigger one. Okay. Then meet me, if you would, at figure 18.2, so that we can talk about the anatomy of an artery wall and a vein wall and a capillary wall. So you can see the similarities and differences in the anatomy of an artery, the anatomy of a vein, the anatomy of a capillary. Arteries and veins both have 3 layers to their wall, and each layer is called a tunic. You know, a tunic is like a coat, right? I don't know if it's like ancient Romans or ancient Greeks would wear like a coat called a tunic. It just means a coat. There's 3 coats or layers to the wall. But we really sort of, they're always said in this really Latinized, what do we call them, tunicas. So there's an innermost layer, the tunica intima. There's a middle layer, the tunica media. Sorry that it's also Latinized. There's an external layer called the tunica externa. The intima, the innermost layer, is sometimes called the tunica interna also. I see it elsewhere referred to as the tunica interna. Either way, that seems more comparable to the externa, they say here. We call it tunica intima or tunica interna, either way. It's the layer that's lining the lumen of the blood vessel. Wait a minute, have we not used the word lumen yet this whole semester? Remember it from AMP1? The lumen is the space inside of any hollow organ. So like urine is accumulating in the lumen of your urinary bladder right now. Or blood flows through the lumen of a blood vessel. The lumen, the space a baby develops in the lumen of the uterus. The tunica interna is the layer of the wall, of the vessel wall, that's lining the lumen. That includes the famous innermost of all epithelium. Simple squamous epithelium, you'll remember the thinnest of all epithelium, simple squamous, lines the inside of our blood vessels. We're going to call that endothelium here, because inside of your blood vessels is as inside of the body as it ever gets. So it's the internal most endo of all epithelium. So we call it the endothelium. I might have said last week, wait, we're still reviewing for our quiz. Remember there's 3 layers to the heart wall, epicardium, myocardium, and then lining the heart chamber, there's the endocardium, right? I hope I said last week. That endocardium is simple squamous, and it's continuous with this endothelium that runs through all your blood vessels then, and back into the heart again, for the endothelium again. So there it is, endothelium, And the tunica interna includes that endothelium plus a little bit of connective tissue elements. Remember that every epithelium is supported by underlying connective tissue. So we don't have to get into all these elaborate phrases here. Just endothelium plus underlying connective tissue is the tunica interna. I'm interested in you seeing the difference of the tunica interna between an artery on the left of our screen and a vein on the right of our screen. Because it's here, it's the tunica interna layers that flop inward to form the valves of our veins, and no such thing is present in our arteries. So how is there any difference between tunica interna in arteries versus veins? Well, in the veins, the tunica interna forms valves. That's the only difference I'm asking you to see. Then when we get to the tunica media, that's mostly a smooth muscle layer in the walls of our vessels. And there's smooth muscle in the wall of the vessel, whether it's an artery or a vein. We already know, because we already talked about, like, for instance, blood clotting. Oh, you just told it to me on your quiz last week, didn't you? About vascular spasm or vasoconstriction. This smooth muscle is what can control the diameter of the blood vessels. But we have much greater control over the arteries than we do over the veins. So I'm interested in you seeing that the smooth muscle layer, called the tunica media, is much thicker in an artery than it is in a vein. Thinner here, thicker here. Arteries are more muscular walled vessels. And you can see this in a dead tissue sample. Maybe you got to see this under the microscope in lab, but if you look at a dead tissue sample, the artery always remains much more patent, open, more rounded with the lumen still open, whereas a vein, it's floppy walled, it just collapses. Because there's so much more musculature in the wall of the artery than the vein. The arteries are stronger, thicker walled vessel. So smooth muscle is the tunica media, artery has thicker than the vein does. The tunica externa is a connective tissue layer around the outside that offers a great deal of structural integrity to the vessel. It makes them much tougher, this external layer does. And it's got collagen fibers in it, that's true. But I want you to see that in any organ, wait a minute, remember in chapter 1, the very definition of an organ was any body part made of 2 or more tissue types. And blood vessels count as organs. Because a blood vessel has multiple tissue types. Here's an epithelium, here's smooth muscle, here's connective tissue. There's a lot of different tissue types. It's definitely an organ. Blood vessels are organs for sure. I want you to see that whenever there's an organ, the connective tissue layer of its wall is where the services come to this organ and come out of this organ. You know, every organ needs to be serviced by the body. Just like every house in a neighborhood has electricity going in, water going in, sewage coming out, right? Every house gets services, like electricity and water and other things. I don't know what, a telephone line used to go into houses, doesn't anymore. A TV line, which there's still some of those going into houses, right? And then the sewage, I guess, is the thing that comes out. And every organ needs to be serviced in a similar way. But the services all come in and out of the organ through the connective tissue layers. So when they show us this connective tissue layer on the outside of this artery, I want you to see that in that connective tissue are all the services. That means that there's nerves running through there. The organ is serviced with nerves, of course, right? And there's even blood vessels running through there. Because the wall of this organ needs blood supply. Even though I know you're thinking, wait, isn't there a lot of blood moving through there? Yeah, but in a big artery, that blood's moving way too fast to nourish the wall. So the wall itself needs to have tiny microscopic capillaries all through here. So they're trying to show you blood vessels. Nerves are in there, lymphatic structures. We haven't really talked about the lymphatic system yet. Often there's like glands and things that are in that connective tissue layer. Those little blood vessels in there, our book loves to call them, and others do too. They love to call those the vessels of the vessels. See, even your blood vessels have blood vessels in them. In their walls, the larger ones do. So they call them the vasa vasorum. Vessels of the vessels in Latin, and the tunica externa. Don't test and quiz questions and national board exam questions. Don't they all just have to do with like the similarities and the differences? What's the similarities between an artery and a vein? 3 layers: intima, media, externa. Same layers in both arteries and vein. But what's the differences? Well, the veins, tunica, intima forms valves, the arteries doesn't. The arteries tunica media is thicker with smooth muscle than the veins are. And then we didn't mention any differences with the tunica external. So the similarities and differences we already just went over. Okay, then that all that's left to do then is to say, look at how simplistic the capillary structure is. The capillary is almost only just simple squamous epithelial cells forming an incredibly thin, semi-permeable membrane as the wall. I want you to think it's a semi-permeable membrane where things can diffuse across, oxygen and nutrients diffuse out through the capillary wall out to your tissues, CO2 and waste products diffuse in from your tissues. But remember this general rule from A&P1. Every epithelium has an underlying connective tissue. So even here, there's still the very most basic of connective tissue elements supporting that epithelium around the outside. They're just showing us a basement membrane here. There's always got to be some supportive connective tissue elements, even when they're really minimal here so that they don't interfere with diffusion. The capillary then, everybody, lacks the smooth musculature of the tunica media, and it lacks the substantial outer connective tissue of the tunica externa. The capillary is essentially just the tunica interna, or tunica intima. It's just the epithelium and a little bit of connective tissue, underlying connective tissue elements is all. Because we need to be extremely leaky so that we can make our exchange. Okay, I'm thinking that this concludes all of our exam material regarding the cardiovascular system in cover chapter 17, 18, and I guess 3 pictures in chapter 19 is all. Right? It's not at all a whole chapter. 3 pictures in chapter 19 is all. So we'll take a quiz and a break, and then we'll talk about a few endocrine system things to help prepare for our exam next week. Okay.